The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Hello, everybody. Hi there. We are here for the next episode of TMD Demystified, and I am Tony Urbanek. Today's title, today's topic, issue number 198. We're approaching the 200th episode of TMD Demystified, and I encourage anyone who's really interested in getting into the nitty-gritty, the meat of this whole problem. It's all contained in the prior 197 episodes, if you're willing to invest that much time. But it's all quite simple. It is not complicated. And frankly, we don't need specialists in facial pain, oral facial pain specialists. That was the latest, biggest mistake that the ADA ever has done, is make oral facial pain a specialty, because 98% of the oral facial pains is fully explained if you understand TMD, which brings us to the point that if you want to understand it, you can start out with episode 1 and come up to episode 198, and you will fully understand TMD. Today's episode is entitled, How Does Chronic Inflammation in the TMJ Cause Joint Locking? You know, I am so familiar with this. I have to remind myself that I am so familiar with the pathophysiology and the anatomy and the history and the symptoms, and dealing with literally over 10,000 patients with TMD in my career. Roughly we're up to probably 6,000 or 7,000 patients in the past 14 years non-surgically. And then the surgical issue part of my career, which went on for 36 years. I mean, you can add easy another, well, I know the numbers, over 2,000 temporomandibular joint surgeries. So not everybody had surgery. Probably you can add another 1,000, 3,000 there over 36 years of consultations with patients with TMD, and 2,000 TMJ surgeries. So lots of experience. My point being that all the material is there. It is not complicated when you understand the pathophysiology and connect the dots on how to treat this non-surgically. But today's title, How Does Chronic Inflammation in the TMJ Cause Jaw Locking? I have to remind myself that most people are not even close to being familiar. They're not even familiar with the anatomy, and it is a mystery to them, even for doctors who treat TMJ surgically and non-surgically, whether it be with a total joint replacement or be with it the night guard, which has no effect on the TMJ, but they don't even understand. They get a patient with locking and they have no idea what's going on with the locking. You know, they read something that really may or may not be true, and they may not have any understanding at all. So we're going to cover today, and it is not complicated at all. So let's start out, because I decided in this particular issue we have to show a few diagrams to make the point. I can use my hand motions and things like that, but a few diagrams I think will make it very clear as I monitor the diagrams with what I say. So let's share my screen and show you a few diagrams that I have used routinely when it comes to there we go. All right, so first we're just going to go over a little bit anatomy regarding the temporomandibular joint. Hopefully anyone who is watching this video will know a little bit about this if you are a dentist, but when I'm finding out that many people watch these videos who are not professionals, so maybe it is a good time we show a few diagrams. So here's a normal joint. Joint is composed of the condyle sitting in the glenoid fossa. This is the fossa itself. This is a joint actually in motion. The first half of joint motion is a rotation when the condyle fits up here in the glenoid fossa, the socket. When it is in that position, the first 25 millimeters or half of opening is a rotation. It is a rotation that allows you to open halfway. And then beyond the first 25 millimeters or so, the condyle, to get open the rest of the way, has to slide down the temporal eminence. It slides down the posterior aspect of the eminence here, dragging the disc or meniscus or cushion, as I talk to patients about it. This cushion made out of cartilage, it drags it with it down the eminence to allow the jaw to open the rest of the opening from 25 millimeters to 50 millimeters on average, 50, 55. Occasionally you see somebody 60, sometimes 50, 52 is a normal opening, but anything below 45 millimeters is an abnormal inability to open. All right, the point is that is the normal function and how a temporomandibular joint functions. The temporomandibular joint, as you know, is not taught in dental school other than it's a complicated joint, which it is not. Dental schools teach this joint is complicated. This joint operates like any other joint in the body, just because it has a fancy name, gangliomo-arthrodial joint. That's the proper designation and classification. Somehow that makes it complicated, which it's not. So now you see how a normal joint operates. And when the condyle, hopefully you can see my pointer here, is pulled down, goes down the eminence, it drags this posterior tissue with it, and the extra space here, besides the ligaments, these are retrodiscal tissue is what we call it, but these are ligamentous tissues here that are able to be stretched, and in between is a vascular space like a sponge, and it fills with blood. So as you pull the condyle down, the extra space here fills with blood. And that is why when I did 2,000 temporomandibular joint surgeries, the posterior aspect of this area would be very, very bloody when it was chronically inflamed. It would just bleed like stink, and you'd have to be ready with your bovie to take care of that rather profound bleeding coming from the posterior attachment in chronically inflamed temporomandibular joints. So this is kind of normal how the mandible works. And of course, the mandible itself is attached to the muscles, lateral pterygoid, medial pterygoid, mylohyoid, which actually, as they contract, bring the mandible down, bring the jaw open. As the condyle comes down the eminence, the surfaces that are under pressure or work are these surfaces: the condylar head itself, excess pressure, and the superior aspect of the disc or meniscus or cushion. Kind of self-evident. So here's really what you need to know about what's going on with the jaw locking. Why does my jaw lock? How does the patient's jaw lock? Very, very simple. First of all, you need to know there's one other part to the mechanism of the temporomandibular joint, or any joint. You have the cartilage, you have the condyle bone, you have the socket, or in this case, glenoid fossa, but you also have the fluid that is inside that joint, and we call that fluid synovial fluid. It is a lubricating fluid. Synovial fluid in its natural state is very lubricating, which allows this. Let me back up here a minute, just for the heck of it. I can do that, because it's lubricated well as the condyle pulls the disc down the eminence with it. Because it's lubricated well, it easily comes down along with it. And when the jaw closes, the disc stays in this concave area, and it comes back down in the glenoid fossa in normal fashion. And it only because the synovial fluid within the temporomandibular joint, the lubricating fluid, works really well. And synovial fluid is like a very, very fine oil, the kind of oil, the gradient or characteristics of oil that you'd use on a very, very expensive wristwatch. Very, very fine oil, even more so. But again, instead of calling it oil, we call it synovial fluid, lubricant. Now, here's what happens when you have chronic inflammation within the temporomandibular joint, causes locking. The first thing that happens with a joint going bad is the disc and starts to click. And in that case, when you get past the rotation part, the condylar head pushes the disc, not pulls. This disc is not pulled forward, it is pushed forward. And the reason that it is pushed forward is because under the influence of chronic inflammation, the synovial fluid becomes sticky like glue. Chronic inflammation, here is the take-home message right here. Chronic inflammation, it's in the literature. It's been in the literature for over 50 years. Not my literature, the general science literature. 50 years of chronic inflammation will create a sticky, gluey type thing. Now, when the condyle comes down the eminence, it pushes the disc in front of it to the point where then, if it is in the earlier stages, the disc will click back. That's why people will, early on this problem, usually in their teens, in their early teens sometimes, they'll talk about clicking, click, 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 not painful, not a pop. A pop is what you're looking at here. When you start getting really loud noises, a pop, that is the disc popping back because you still have enough traction from the ligaments that it'll click back. These ligaments are like rubber bands, and as long as you have enough traction on the rubber band, it'll pull the disc back when the condyle goes back, and then it will become back into its proper position, but the patient will complain of a loud pop, and usually a pain, some kind of pain that goes with that. That is in kind of the middle stage of getting to be locking. You get clicking, click, 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 open and close. And then you start getting popping where the disc is pushed down because now the synovial fluid is like glue and it doesn't adhere at all to the top of the condylar head. It is pushed forward. And then when it's pushed forward far enough, the meniscus or disc or cushion will pop back into its normal expected position and then make a loud noise and some pain.